everybody, and welcome to the Research Roundtable. Okay, this is going to be fun tonight because you know what happens when you have two people in the same Zoom room that really know each other, that really work closely together, and that are truly passionate about patient care and outcomes. Well, that's what we've got tonight, and we're so excited to welcome our special guest. But I do want to ask you to let us know who's in the audience. So give us your name, where you're logging on from. Sometimes what happens in chat is almost as exciting as what happens during the webinar. But our guest is Melissa Seaton, and she works at the Roxbury Institute with Dr. Herbst, a board-certified nurse practitioner with over a decade of experience in healthcare, specializing in integrative and preventative medicine. Her approach blends evidence-based conventional care with functional medicine principles to help patients achieve optimal long-term health. She is currently pursuing advanced training focusing on nutrition, exercise programming, peptide therapy, and gut health. And you can bet we're going to talk about all of those things. And when I read her bio, I was equally touched by her origin story. I think you'll all enjoy hearing that too, but I will leave that to Dr. Herbst. By the way, please do put your questions not in chat, but in the Q&A. Dr. Herbst will get to them as she can, and I will disappear and let the conversation begin. Take it away, Dr. Herbst.
Thank you, Brenda, and welcome, Melissa. I hope to have you on over and over again. So, Melissa and I have been working with each other for how many months now? 4, 5 months? 5 months. Yeah, 5 months. It's gone by really fast. It's been amazing. You are such an incredible person and one of the fastest learners I have ever met, which made my job easy. And you've taught me a lot too. So thank you so much. So I am very excited about tonight because we've been doing a lot of research roundtables on like surgery and medicines and histology and, cell physiology. But one of the things that we talk about all the time in each of our clinic visits with our patients are lifestyle. So diet and exercise. And you have expertise in this area. So I guess I would love to just hear your story about, where you've come from and why your interest in diet and exercise.
Sure. Well, first of all, thank you for having me. And thank you for the introduction. Getting a compliment from you is huge to me. You are one of the most smartest people I've ever met. So I really appreciate that. And I've learned so much from you in the last couple months. So my origins I started out as a very overweight child. I like to joke that my mom showed love with food. And so I was very loved, but I was very overweight. I remember looking for a dress for something called the blue and white ball in 8th grade. And I think I couldn't fit into anything. And we ended up having to go to like the plus size section. And I believe the dress I ended up buying was like a size 16 or 18. And I was in 8th grade. I wore, at the time, they called them husky jeans, which, God, what a terrible branding. I don't think they call them that anymore. But they called them husky jeans. So I grew up very overweight. And when I got to college, I just decided that I didn't want to be overweight anymore. And I thought to myself, there had to be some other way. So I actually met with a registered dietitian in college and started exercising, got really interested in fitness. And then that path led me down the path of wellness. I realized I could lose weight, but I also realized that I wanted to be well. And so I got into healthcare. I became a nurse and I loved nursing. I worked critical care for a long time, but I realized that critical care was often the end of the road for most people. And some things happen, car accidents, things like that you can't prevent, but I saw a lot of preventable diseases. And so I really wanted to know, why did we have these diseases and how could I help people prevent them? So I went back and got my nurse practitioners and started in internal medicine. And even then I loved where I started, but I very much was like, why? Somebody would come in with acid reflux or complain of heart pain, or, heartburn, or they would have diabetes. And I would always say, okay, but why do you have these? And so that really pushed me into a functional medicine fellowship where we do try to figure out root causes. And so I was trying a different gig for a little bit. I did some aesthetics and wellness and realized aesthetics just wasn't for me. And I stumbled upon the Roxbury. I feel like I was kind of led there. It kind of found me, and I interviewed and I found out what you were doing, and I was like, this is it. And it is, I say it all the time, but I feel like I found my calling and exactly where I'm supposed to be. I've always been the person that's like, okay, what's next? What's next? And here I feel like this is what is next for me. And there's so much emerging research in the field as far as genetics go. There's so much we still don't know, and still so many people to help every single day. So I feel like I have found where I'm supposed to be. So
Yay.
excited to be here. Yeah.
That is exciting. I got the chills down my legs and onto my shoulders. That's big. So, so how do you treat lipedema, chronic venous insufficiency, and lymphedema? Like, what do you feel your role is there?
So at the Roxbury, we have a lot of patients who come and visit us and they don't have a diagnosis. So they feel as though something has always been wrong. They'll tell us a lot of times, I feel like my legs belong on somebody else, or I have all these signs and symptoms in my legs and even their arms and abdomen sometimes. And we hear often that providers will just say, you need to lose weight, you need to diet, you need to exercise. And so we get a lot of patients like that. And so we start often with a diagnosis. And with lipedema, that looks like we feel the tissue, we look at the tissue, we evaluate their signs and symptoms. Maybe they have leg heaviness, dimpling of the tissue, swelling. And then we'll also take pictures with thermography, and that can help us kind of identify some potential leaky vessels. And so all of that combined, we will get a diagnosis, and then we come up with a treatment plan for them based on that diagnosis. And that may include things like sending them to a vascular specialist or even seeing somebody for some manual lymphatic drainage.
So how many people with lipedema that you see do you think have some vascular issues or chronic venous insufficiency?
Ooh, I would say a lot. I would say, and I'll ask your expertise on that because I know you've been doing this a lot longer than me. But so far, most of my new patients that I have seen, I would say more than half of them have some sort of component of vascular disease, and maybe not necessarily large vessels, but I would say they have some dilated small vessels in just about all of them. What about you?
Yeah, I'd say probably all of them have dilated small vessels. And for chronic venous insufficiency, you have to go with evidence-based data on that. And the literature says up to 90% of women with
Yeah.
lipedema have chronic venous disease. So that could be varicose veins, that could be venous insufficiency. So that's a lot.
When
And mhm.
when you first started, Dr. Herbst, do you feel like it was as common to see people? I mean, you probably saw that component of it, but do you feel like it's talked about more now with the
Oh,
chronic venous
100%.
insufficiency?
Yeah, when I first started, if I even mentioned that blood vessels were important in lipedema, I was laughed out of the room. So it was all about the lymphatic system and only the lymphatic system. And now we know that it's a systemic disease and really everything's involved. It's a connective tissue issue. It's the fat, it's the vessels, it's the immune system, etc., the nervous system. So it's
Mhm.
much more to learn.
Yes, for sure.
So, what do you think is your best diet for lipedema? Like, what do you recommend in terms of food?
Um, I've always been the kind of person, I don't think there is one size fits all. I think, but I do think that an anti-inflammatory approach is going to be the best for any kind of chronic disease, and not just lipedema. We know lipedema is a chronic disease, but we also look at diseases like cardiovascular disease, diabetes, and we know that an anti-inflammatory diet is going to help that. Anti-inflammatory looks a little bit different for everybody, but they have similar principles across the board. So you look at a whole foods diet, lots of fruits and vegetables. I tell people, don't complicate it. Just eat the rainbow as long as you feel good and, listen to your body. But lots of fruits and vegetables, berries are going to be great. You want to make sure you get your fiber in. You want to make sure you get enough omega-3s, which are going to be anti-inflammatory. So that's going to be, you can take an omega-3 supplement, but also fatty fish. So salmon, sardines, if you'll eat them, anchovies, if you'll eat them, olive oil, olives, avocados, all of those are going to be very good for you, anti-inflammatory. And then I usually just tell people to limit really processed foods. I tell them to not necessarily restrict carbohydrates, but to be mindful of their carbohydrate intake and try to choose carbohydrates that have less impact on blood sugar. So your berries, fruits and vegetables that have fiber in them. And then, of course, limiting things like alcohol.
Mm-hmm. And would the diet differ for somebody who is not obese, does not have obesity, but has lymphedema? Would it change in
So
your mind?
for me personally, and I'll get your intake on this too, Dr. Herbst, I don't think so. I think an anti-inflammatory diet is going to be beneficial for anyone across the board. I think with the lymphatics, there are some things that, you pay attention to. And even if someone's not obese, they're still going to benefit from eating an anti-inflammatory diet. I know there's some debate about sodium restriction in lymphatics and whether or not you should reduce sodium. That's one of those things where I think, again, processed food plays a role in it. Most processed food, especially, if you're eating canned things or things like bacon, things that are full of salt and sodium, you're going to have increased swelling. But if you're eating mainly a whole foods diet, you're probably getting the right amount of sodium in your diet. So I don't think you really should make that big of an adjustment for it. I know there's a couple of different studies out there and I know we'll talk about some things in a little bit, but there are a couple of different studies on that. I think an anti-inflammatory approach for anybody across the board is best.
So what about the other fat disorders like Derkham's disease or Madelung's disease? Would your diet differ for those individuals?
So will you explain it? I feel like if I do it, it's a disservice because I know Madelung's and Derkham's are your babies. So would you explain to everybody what those are just in case they don't know?
So Derkham's disease is a painful fat disorder where you get lipomas or lipomatosis pretty much all over the body. It starts usually on the trunk or a limb, but it doesn't have that characteristic asymmetry of the body with the larger legs and the smaller trunk that lipedema has. And it's just very, very painful and associated with more pain issues like migraines and especially abdominal pain. And Madelung's disease or multiple symmetric lipomatosis is fat present more on the upper part of the body, although it can be whole body, but a lot of times it's around the neck or on the upper arms, especially in women, and on the back. And then again, it can progress downward. And even there's a very rare kind that can look like lipedema, but it can have angiolipomas in there, so a very vascular type of tissue.
Thank you. Thank you for that. I feel like I would have not done as well explaining it. So I think both of those conditions benefit from an anti-inflammatory approach. And there's limited studies, but there is a case study of a lady who was diagnosed with Madelung's and felt like traditional conventional methods were failing her. So she took lifestyle interventions into her own hands. She actually did some restricted feedings. So she only ate which, like intermittent fasting. She didn't eat for 16 hours. She restricted her carbohydrates. She went to more of a ketogenic approach. She did less than 10% of her diet as carbohydrates. The rest she did fat and protein. And then she also focused on some factors like sleep, stress reduction, and then exercising. And she actually had significant improvement in her condition.
Nice. So more of the keto diet.
Mm-hmm.
What about
And
carnivore? How do you feel about carnivore?
I know. We see patients who, they'll come in and they'll say, I do carnivore or I started ketogenic and I feel the best I've ever felt.
Yeah.
So my take on it is if you want to do it and it makes you feel good, and then I support it. Personally myself, I've tried like a lower carbohydrate diet. I've tried ketogenic. I didn't do well on it. And I think a lot of people, I think it's very hard for them to stay on it for the long run. So I'm really big on finding sustainable diets that people can do for, the rest of their lives. I don't like things where it's a trend or a fad, you do it for, and I'm not saying that those are, but if you're the kind of person who's like, I'm going to go all in for 3 months, I'm going to do this diet, and you lose all this weight and you feel great. But then as soon as you stop that diet, you can't stop eating, carbohydrates, and you gain a bunch of weight back. I think that a lot of times you end up unhealthier than you started. So I think if you want to do it and you feel good, do it, but just be mindful of, is this something that I could do forever?
Yeah, I agree with that. You can't yo-yo on and off. And we've had some patients who have had trouble with their lipids, their
Mhm.
cholesterol on keto diet. But again, some people do extremely well. And again, that fits exactly what you said, that you don't pigeon yourself into one diet. You work with patients and personalize it to them. And I really like that. So we've got some questions. Nancy Thies says, tell me more about thermography for chronic venous insufficiency. Is this the same machine you use for breast imaging? And where can I find a practice that employs thermography?
You want to answer that, Dr. Herbst?
Uh, well, thermography, there is a device. We use a non-clinical device because we're only using it for our practice, and we aren't writing reports on it and using it for clinical diagnosis, but it helps us to get to know you as a patient. And so there is a thermography device for chronic venous insufficiency or venous disease. It's available on the market. So you could look for a vascular practice that has thermography. And you can also buy a thermal camera for yourself to get a, better look at your tissue. And we use it for so many different things, for um, locating hot spots or cold spots. And, lipedema tissue is supposed to have some hypothermia or cold areas. And, we note those in our note as part of one of our diagnostics for lipedema. And it just gives us a little hint that maybe you need to go see a vascular specialist, and it gives us a little hint of how vascular you are and whether you might have some leaky vessels that need to be treated. So let's say somebody goes on an anti-inflammatory diet and they're just not feeling great. They have some abdominal pain, um, and they're noticing that when they eat certain foods, they're not feeling as well. What would you do then for them?
So that's when advanced testing can come into play. And again, this is one of those things that I personalize per patient, because some of the advanced testing, and we're talking about things like MRT or food allergy testing or gut microbiome testing, they can be expensive. And I understand that. So I always have a conversation with my patient about, what does this look like for you? And what are you able to spend? And so we always evaluate that. And if it is something that they're interested in, then it's something we'll talk more about. But MRT testing can be very beneficial because I think it tests 170. Is that right?
Yeah, close to it.
Okay. Yeah. And it tests several different foods, a couple different additives. Am I missing anything else? I know it's got a couple other
Some
things
dyes, some
like
chemicals,
artificial sweeteners.
hmm but
But
mostly
essentially,
food.
mostly food. And it'll come back as like a green, yellow, red on a report. And if it's green, you're in the good. If it's yellow, you need to be mindful of that. If it's in the red, it's essentially saying that you have a high reaction to that. So something like MRT could be beneficial for someone who is eating an anti-inflammatory diet and is telling you, I don't feel good. And so that would give us a little bit more insight onto why, especially let's say they eat a lot of tomatoes, bell peppers, things that have a lot of antioxidants in them and are supposed to be good for you, but it comes back that they're in the red on the test for that. Then I would tell them, typically you start with an elimination diet. And so we would say, why don't you eliminate these for X amount of time? And then we will slowly reintroduce them. But we will, of course, pay attention to whether symptoms come back. And then gut microbiome testing can be pricey, but it can be very beneficial for someone who, let's say they've done all the things. Maybe they've done MRT testing or they've kept a food journal and they've identified their triggers. Maybe they avoid gluten and dairy and they've noticed that they still bloat or they still have issues with constipation, diarrhea. So a gut microbiome test can be really great in the sense that it gives you several pages of data on what's actually going on in your gut. It will go over opportunistic bacteria, which is essentially bacteria that lives in the gut, but given the right opportunity will overgrow. So an example of that would be like staph or strep. And in really high quantities, they can cause a lot of issues. They can cause things like excess diarrhea. They can cause gas, bloating. It also tells you some inflammatory markers in the gut. It looks for a couple parasites and then tells you essentially the health of your gut. So I think somebody who has kind of done everything and really has dialed in their diet and is still having all these symptoms, I think that's when those tests can be very beneficial.
Do you think patch testing or allergy testing, through an allergist would be useful to some people?
I mean, we see a lot of patients with mast cell activation syndrome, and I know
Hmm.
sometimes they'll find that useful in the sense of like, I was told I was allergic to this, I was allergic to cats, or I'm allergic to dogs, or this type of grass, or this type of weed. So yes and no. I don't think it's as beneficial when it comes to food allergies, but I think
Hmm.
it can be beneficial in other areas. What are your thoughts on that?
Yeah, I think there's some allergists that won't test for food because they just don't think it's that accurate. But
Mhm.
yeah, I had allergy testing for food and I thought it was pretty helpful. But I went on to do the MRT test because I was not allergic to wheat. And I found out through the MRT test that I am very strongly sensitive to wheat. So after I've eliminated that completely from my diet, I feel so much better. So
I did it,
useful.
and I found out I used to love putting like lemon and lime in my waters,
Hmm.
and my lime came back in the red, and I used to drink a lot of lime, so I don't anymore.
Hmm. Yeah, I think it's just another test that you can do to improve the quality of your life and to get more data about yourself. Data is so important. And we do have that test through the Roxbury, and you can get it
Mhm.
through other places as well. So, in addition to diet, what what kind of other like medications and supplements would you use to support your patient population? What do you recommend
So
on a regular basis?
sure. So I always start with diet. And I tell people one of my favorite analogies is something I kind of made up, but I tell people we're in a boat and we all have holes in our boat. And you have to look at like diet, stress reduction, sleep as some of the biggest holes in the boat. And so I love to look at supplements as a tool. But let's say, you have a hole in your boat this big and that's your diet, and we put this little supplement in there and try to patch it, we're still gaining water, right? So I personally take a lot of supplements myself, and I do love supplements, but I like to tell people like get down your basics and then let's do the supplements.
Mhm.
So we use a lot of Vasculera, which is diazepam. It's a micronized purified flavonoid fraction. It's which we like Vasculera because we know that the MPFF portion of it is actually absorbed in the gut, whereas you'll see a lot of diazepams on the market and it's not actually absorbed very well. So we like to tell people in clinic, this is a little pearl I got from you, that you just have expensive poop. So we try to make sure that they're getting good quality supplements. We both use, Dr. Herbst and I both love magnesium. We recommend a lot of magnesium to patients. There's a couple of different types of magnesium. Magnesium glycinate has been shown to be really good for athletic recovery as well as sleep, stress, and anxiety. Magnesium L-threonate actually is the only magnesium, I believe, that crosses the blood-brain barrier. So it can also help with some cognitive improvements as well as anxiety. And so we use a lot of magnesium in our clinic. We also love vitamin C. Vitamin C is a powerful antioxidant. It's anti-inflammatory. And we've actually seen there's some promising research coming out on high dose vitamin C with reducing inflammation and using it in things like cancer. So we use a lot of vitamin C. And then I like omega 3s. I tell everybody, most of us don't eat enough omega 3s or we don't get enough fish in our diet. If you eat a lot of fish, you can skip the omega 3s, but omega 3s can also be a powerful antioxidant. And those I would say are kind of like the big ones I use. What about you?
No, I agree 100%. I was thinking about the omega 3s. There's so many different fatty acid supplements on the market right now. So
Mhm.
it would be nice to have like a whole episode on just all the different ones. And I switched to a different omega fatty acid. I was using Nordic Naturals and I like them because you don't get those fish burps. But there's another one called Accentrate, and that is supposed to better cross the blood-brain barrier. And for, I'm getting up there in age, so Alzheimer's is looming and I don't want it. So I've been taking it, and I actually think it does make a little bit of a difference for me. It takes a long time to get there, so I've been on it for about a month. And I think it takes about a month for you to start noticing that your brain is working any better. But I agree with you 100%. And can you talk a little bit about what, people can take vitamin C. What form is the best form to take it in? And can you get high dose vitamin C?
Sure. So I like liposomal vitamin C, which means they just put a little fat molecule with it. It helps with absorption.
Mm-hmm.
So, and again, these are just brands that I've tried. Quicksilver is one that comes to mind. It's a liposomal vitamin C. It comes in a liquid. You keep it in your refrigerator. You have to be careful with high dose vitamin C if you're taking it the oral route, because it can cause gastric issues. So if you take too much vitamin C, you can end up with diarrhea, maybe a little bit of nausea. So I usually tell people to start with like a gram and see how they feel. And then they can add another gram, add another gram. Ideally, we get them up to 4 to 5 grams if that's what they need without any GI side effects. And then for someone who is having a lot of pain and inflammation, I know recently we saw a Durkheim's patient who was having a lot of pain and inflammation, and we recommended some high dose IV vitamin C. So
Mm-hmm.
there's a lot of like IV shops that have popped up. I would obviously recommend you find somewhere in your area that's credible. Look for one that's owned by a medical professional and that has a medical professional on site at all times. But you could go there and get a high dose as long as they offer it. They offer different ones like Myers cocktails, which have B vitamins and magnesium. So you could just go to one of those places and ask for a higher dose of vitamin C.
What's the typical high dose vitamin C? What is the dose?
I will say 15 to 25 grams. And you have to be careful because once you get past like 20 grams, you really do need to have your G6PD status tested, just to make sure that you're not going to run into issues with a high dose vitamin C. But
Yeah.
usually
And
around there. And some places are doing more than that.
you can get your G6PD status tested through your local lab. So if you are considering high dose vitamin C, I'd recommend that. And I don't think as many places are going to do 15 to 25 milligrams versus maybe giving you 5 grams IV, like in a
Yeah.
Myers cocktail or something like that.
Yep.
So we've got a couple questions. Back to the MRT. What does MRT stand for? Can you explain that
And
test a little bit better?
sure. It stands for mediated release test. And Dr. Herbst, do you want to go into the science on it? Because you do a
Sure.
better job explaining.
Sure. So it is a functional test. It's not a typical test that you would get through a lab that's already, run through large randomized controlled trials. So I know they do have like one research study, they need more, but we don't have a lot of functional immune tests. And so I really like this one for that reason. So what they do is you send in your blood, it's shipped to them. They use your cell. It has to get to them at a certain time. So you have to send it after 2 o'clock in the afternoon. So it gets there overnight, and they run the test the next morning. And basically they look at the size of your cells, and your immune cells have a lot of little packages inside that they like to ship out like bombs. And that's, if they encounter an invader like a virus or a bacteria, and if they get really pissed off and they shoot out a lot of bombs, their size gets smaller because they're no longer holding all of those little packets. And so what their immune cells are releasing are mediators. And so it's called mediator release test. And they actually just look at it by size. And so if you really shrink down your cells because they're really pissed off and shooting out lots and lots of bombs, then by the very small size that it's a positive test. And it's all for food, again, food and dyes and things like that. Okay, so I think we answered what about a high protein diet? We definitely like high protein diets for our patients who really feel good on them. So we answered that one. We did that one. And then how do you spell the M disease that has angio? Oh, that's Madelung's, Madelungs, or it's also known as multiple symmetric lipomatosis. And does insurance cover the MRT test? Unfortunately not. not yet. It's got to go through a lot more clinical testing for that. And then the type of magnesium that crosses the blood-brain barrier, that's magnesium threonate, threonate. So I can put that in there.
And Life Extension makes one that's called NeuroMag, and it's got the L-threonate in it. It's called NeuroMag.
And I'm just going to have you answer this one. It's
Sure.
it's a little bit off topic, but it fits on the medications. Do you have any new information coming out on tirzepatide helping lipedema?
So I'll just tell personal experience with the
Yep.
clinic.
Mhm.
I use it on a lot of my patients. And they feel good. So we microdose it. So a standard dose of tirzepatide, a starting dose is going to be 2.5 milligrams, which on an insulin syringe is going to be 50 units. And we usually start people on 3 units and they increase by about a unit a week. So they're on a fraction of the dose. And I was actually having this conversation with a patient earlier, 2.5 milligrams. And you can correct me if I'm wrong on this, Dr. Herbst, but I'm pretty sure that like Eli drug makers just consider that a starting dose, not even quite a therapeutic dose. Is that correct?
Correct. It's a
So,
microdose according to them.
okay. Yeah. So we usually, I would say vast majority of our patients are on a microdose. Most of them are on 2.5 milligrams or less. And we see things like a reduction in their symptoms, a reduction in their pain, sometimes reduction in the heaviness and swelling that they feel. Not always the case, but some of them have just told me, I feel better and I can't really explain it. So that's my just, information from working with people who are using it for that. And I know you've had similar experience, Dr. Herbst.
Yeah, I mean, we've gotten patients who've lost quite a bit of weight on tirzepatide, and they're just down to their lipedema nub. And it's just a little bit more fibrotic tissue, and it's going to take a little bit longer to go away. And we pretty much so support the use of tirzepatide, but we do have some patients who are on semaglutide, would be the Ozempic, Wegovy, but we use the Mounjaro, Zepbound, or tirzepatide, and that's because we can microdose. If we want to use semaglutide, we'd have to go through a compounding pharmacy, and we've had some not so good results from compounding pharmacies. And we've had some good results from compounding pharmacies. It just depends on the pharmacy. It's just the compound, it's so hard we have to use a different website. They have a different concentration. So instead of 2.5 milligrams and half a mil, it's 17 milligrams in 0.75 mils. It's just a little bit more complicated for calculating things, but there's no reason not to use it if you do have a good compounding pharmacy.
What are your thoughts? I want to ask you, Dr. Herbst,
Yeah.
What are your thoughts on retatrutide?
I think retatrutide is going to be a big deal. And the reason is because it increases muscle mass along with decreasing fat mass. And it kind of works paradoxically that way, but it's a triple peptide. And I think there's just going to be more and more peptides as time goes on. And you are going to be able to keep your muscle mass and not regain your weight after you stop it. So I think retatrutide is the next frontier, but there's other ones coming after that.
Yeah,
So
I know.
yeah. And we've got some patients who are purchasing retatrutide for research purposes and seem to be doing okay, but hard to recommend that when we have tirzepatide and it's been working so well, especially at such a microdose. So we've been talking a lot about food, medication, supplements. What about exercise for lipedema, lymphedema? What do you recommend? And before you answer, one of the I guess rumors going around is that for lipedema, lymphedema, you are supposed to only do low impact exercise, very gentle exercise, nothing that would require a lot of effort, I guess. I'm trying to put the right words on it, but you've heard the rumors.
Yeah. I look at exercise like we look at compression or even eating, I think everybody should exercise. But again, I don't think exercise is one size fits all. I think exercise has to be, you have to find something that you actually enjoy doing and then do it. And so that's my biggest thing. I think everybody can benefit from strength training. We know how important muscle mass is. We know that it's a marker of longevity. It reduces all-cause mortality. It also, even if you're diagnosed with chronic disease or cancer, it improves your prognosis in those depending on how much muscle mass you have. Same thing with like hip surgeries or any kind of fracture in life, it improves all of the outcomes. So especially most females, a lot of our patients are females, a lot of females run the risk of osteoporosis as they get older. And so we know that weight bearing exercise can help prevent that. And so I'm big on strength training. The research indicates 3 days a week minimum is beneficial. Nothing after, you don't get improved benefits after 5. So I usually tell people 3 to 4 times a week is great for strength training. And that can be however you want it to be. So I like total body workouts because I like to get in and get out. So I'll do some upper body mixed with lower body 3 days a week. And then I do usually recommend some sort of aerobic activity. And again, I think that has to be something you enjoy. So if you love to swim, then swim. If you like jogging or running or dancing or, doing Zumba or jazzercise, kickboxing, there's so many different modalities. And so I recommend whatever it is that you enjoy. And then I do think that most of us sit too much, unfortunately. It's the world we live in. We sit to drive. We don't really live in walkable cities. So I tell people to try to walk throughout the day. Get in, a 10-minute, 15-minute walk in the morning, get a 10-minute, 15-minute walk in the afternoon, and then again in the evenings. But ideally, I'd like to see everybody getting, 30 to 60 minutes of walking. And that doesn't have to be power walking. It's just movement. As far as the high intensity stuff goes, I think that's very independent. I think if you take somebody who is already kind of stressed to the max, and what I mean by that is they have a chronic disease, they've been inflamed, and then who knows if we don't know what their hormones are doing or what their cortisol is doing. So then those instances, when you throw in high intensity activity on top of that, it's kind of like fuel to the fire. And that's when I would not recommend it. But I think otherwise, I think high intensity exercise can be great. I think it's very dependent. If it brings you, exercise should be uncomfortable, but it shouldn't be painful. So that's what I like to tell people. Exercise can be uncomfortable. That's part of exercise. But if it's painful, then that's different. So
no pain, no gain.
I don't
Isn't
know.
that what they say?
I know maybe 20-year-old Melissa would have agreed with that, but going on 38, I'm like, no, I got to protect these joints. So
Yeah, I agree. I don't think you have to have a lot of pain. And I think if you are toxic, you have a lot of excess, or you have muscle issues or skeletal issues, connective tissue issues, you really have to be careful. But I still think somebody with hypermobility, a connective tissue issue, can still weight lift in a manner that still will work for them and help them build muscle and be safe. And what would you recommend for somebody? How do they learn? Who would they go to figure that out?
So we see a lot of hypermobile patients in clinic, and we talk about one of the best ways for joint stabilization is through resistance training. So I would see somebody who is versed in that, whether it's a physical therapist or a personal trainer. And you do have to be cautious with personal trainers because a lot of places you can just sign up and say you're a personal trainer. So I would look for somebody who has some actual training, certifications in that. And then I would find somebody who, if you have hypermobility, if you have lymphedema, lipedema, it never hurts to find somebody who's familiar with those conditions. So I would just ask them. And I would say to be open to practitioners or providers who are willing to learn about it. Maybe they don't know everything about it, but one of my patients I met with today, actually, she sees a personal trainer who had no idea what lipedema was. But he researched and he learned about it and he learned how to help her. So, don't shoo everybody away just because they don't know about it. Invest in people who also are going to want to learn about it and they can help you. So that's where I would start with that.
I think that's a good idea. It's good to work with somebody just to make sure that you're not going to cause any joint damage or rip something, which is really
Yes.
possible if you have a connective tissue issue. I really
Yes.
wish we could find the gene for that, and then we could say, oh, you should do this instead of do that, but we don't have it
I
yet.
think you're gonna get there. That's coming.
I'm struggling. Genetics is so freaking complicated. Um, what do you, what practical daily habits seem to make the biggest difference in quality of life for people living with inflammation and edema?
I would say one of the most important things to reduce overall inflammation and stress load in the life is good quality sleep. I think it's highly underrated, but we are starting to see the literature on the effects it has on the brain, and overall quality of life. So, they say 7 to 9 hours is kind of like the sweet spot. I think again, that's depends on the person. If you're laying in the bed for 9 hours, but you're not getting good quality sleep, then don't lay in the bed for 9 hours. But, so I talk a lot about sleep hygiene is what I like to call it. And so I really recommend no blue light about 2 hours before you want to go to bed. So that's no cell phone, no TV. I tell people, I know it's hard. I tell people to read a book or spend time with your animals or your loved ones. But reading has been really beneficial for me. So read a book, but no blue light 2 hours before bed. You want to try to go to bed roughly the same time, give or take, an hour or so every single night, and then try to get up in the morning and get sunlight as soon as you wake up. So we know early morning sunlight helps reset circadian rhythm. So get your sunlight. For people who drink caffeine, I usually tell them to be mindful of caffeine intake. And I'm kind of strict on it. Especially if you're having sleep issues, I don't recommend caffeine intake after like 12. Some people will do 2 or 3 p.m., but if you're not sleeping, then let's cut the caffeine down. And I like things like half calf coffee, or if you're a person who just likes the taste of coffee, then switch to decaf. But so I really recommend sleep hygiene and getting good sleep. I recommend stress management, and stress management can look like a couple different things. Can be meditation, could be something like yoga. I personally use exercise to help me with my stress management. So I recommend some stress management. And then again, good nutritious diet. People underestimate how much that actually affects our daily lives, but it will help you recover. So if your body is healthy, it's going to recover. It's going to sleep better. And with that being said, exercise also tends to help people sleep better. So I recommend exercise for that. And then exercise and drink your water. So those are kind of and be grateful. That's the big
Yeah,
things is
grateful's good.
look for the good.
Mopping your floor is great exercise.
It is.
I had a lot of exercise this weekend. So, um, in terms of labs, what would you order on a patient, or what do you routinely order for patients with lipedema in your clinic, or lymphedema, or venous disease, or any of them? How are you ordering labs? What does that
I
look like for
really
you?
I really appreciate, and Dr. Herbst, I'll get your take on this too. I really appreciate the basic labs to start off with, a good chemistry panel. I want to know what your kidney liver is doing. I like a hemoglobin A1C, but I also really like a fasting insulin, which I know that you're big on.
Hmm.
I like vitamin D levels. We see a lot of vitamin D deficiency in our patients. So I like
Hmm.
vitamin D. And I think more providers now are checking that, but I know personally, I always had to ask for people to check my vitamin D level. So I wouldn't
Yeah.
say that's a common lab that most people check. I like a CBC. I know we also check CRPs a lot to check for inflammation in the body. And those are kind of the big ones I like, but I know you have some more that you really like as far as inflammation goes. You want to talk about those a little bit?
I like mast cell labs, but a good CRP, ESR, if they're angiolipoma or very vascular, maybe a VEGF and a TGF beta. And then, of course, I look for, odd things, um, like for autoimmune lymphoproliferative syndrome, but a good
Mhm.
B12 level for anybody would be would be good. One of the things I want to jump back to, because this is kind of unique. What if somebody comes in and tells you that they just can't wear costume jewelry? Like their ears get so irritated and pussy and they just can't wear earrings anymore. Would that reflect on what kind of diet they should focus on in your mind?
Well, it's interesting that you bring that up because we have recently learned about nickel and nickel allergies and how much inflammation they can drive because foods are actually full of nickel. A lot of foods are full of nickel, and it
Mhm.
always tends to be some of the healthier foods. So, nuts and seeds tend to have a lot of nickel in them. and correct me if I'm wrong, but I'm pretty sure oatmeal does. I know a lot of the so of course, any of your nut milks, almond milk, cashew milk, all the milks that most people are drinking when they try to avoid dairy. And what actually has lower amounts of nickel in it is going to be things like your proteins. And then I'm trying to think of what else is on that low nickel diet. Can you
I
think
think
of
some
anything else?
fruits and vegetables are a lot of fruits and vegetables, but like shrimp is high in nickel.
Hmm.
Um, and chocolate is
I
high in
know.
nickel.
I know.
Tomatoes, high in nickel. So it would be something to look into if you have, like, I'm severely allergic to nickel, and I found out that I was eating only nickel rich foods. So I've switched off that, and I think it makes a difference in how I feel in general. Not as fatigued, able to sleep better. So it's just another angle for you if you do or if you are sensitive to nickel, just to kind of look at it. It doesn't mean never can you eat another nickel rich food again. It just means you kind of treat it like Weight Watchers, and nickel rich foods have points, and you want to stay under a certain amount of points. And there's a website called Rebelytics, Rebellytics, and that has information on nickel content, I think throughout the world,
Hmm.
because obviously depends on where you live and even different parts of the United States. So that's pretty cool. So we're running down on time. I just want to ask you, what do you wish every newly diagnosed lipedema patient knew?
Ooh, that's a good one. Um, I want you to know that you have the power. So, I had a patient 2 weeks ago who came across the country from New York to see us. She's in her 60s, been told her whole life that nothing was wrong with her. She was anxious, or she just had a heavier thighs, heavier butt. And so we diagnosed her with lipedema, and she told me, she said, "I'm so disappointed. I just am so upset." And I told her, I said, "It's okay to be upset and it's okay to be disappointed. But I also think you have the power to, feel the feelings, but you get to attach your beliefs to those feelings." And so I told her, why not change that feeling? The feeling you're feeling right now is uncomfortableness, but why not change that and tell yourself that you are so proud of yourself for knowing that something was wrong with you, for not, allowing people to tell you that it was just in your head. You kept seeking until you found the answers, and you've taken care of yourself. So be proud of yourself. And I really believe that each of us inside, we all have the power to change our lives and to live the life that we want to live. And so don't let it discourage you. It's okay to feel all the feelings when you get diagnosed. And it's not fair, and it does stink, but there is hope on the other side of it. And so I want people to know that there's hope to it, and this is not the end. It's, the best part about being diagnosed is now, and now we have knowledge, we have tools to help you, and we'll help you overcome it. So
Mm-hmm. I back in the day, we really only had surgery, and we didn't even really have that because insurance companies weren't covering the surgery at all. And there were like maybe two surgeons in the US who even knew what lipedema was. And now there's so many different surgeons. You can go pretty much so all around the world and have surgery. Plus, we have the GLP-1s with more peptides on the horizon. So
mhm.
I do think it's a good time for lipedema, lymphedema, venous
I agree.
disease, because there's more things that we can do, and you have a choice. You can,
Mhm.
make a choice. So 5 years from now, after I've retired, how do you think
No way. Don't say
how,
that.
how do you think lipedema care will look different than it does today?
My hope is that you find the genes. I know that's
Or
your hope.
somebody does.
I know, but you also joke and say you're not going to retire till you find the genes. So selfishly, I hope you don't find the genes for a while longer. But I honestly hope that more providers know about it, and I hope there's better access to care, because I think when you look for a provider to treat you, it's so hard to find somebody.
Mm,
And so I hope that there's more access to care. I hope that there's more knowledge. I hope, especially with the ICD-10 codes now, which I'll let you talk about, Dr.
mhm,
Herbst, a little
mhm.
bit more. But I hope it's talked about more in the medical community, and that patients can get more care.
I think that's really nice. Yeah, I did want to mention the ICD-10 code. So we've been working since, gosh, 2020 on the ICD-10 codes. We got a little bit behind because of COVID, and then got back in it. And we just heard from the CDC that we're pretty much so done, and it's going to start moving through, and it takes a while for it to get into, get through the bureaucracy, but that as long as nothing outside of normal happens, which is what I was told, the ICD-10 codes will be available for use in October 2027. And one thing that I wanted to say is we actually have ICD-10 codes for the stages of lipedema, and we also have an ICD-10 code for Derkham's disease, and we have an ICD-10 code for Madelung's disease, or multiple symmetric lipomatosis. And we made some corrections in the lymphedema literature because there was there was an error, and so we fixed that. So and we added familial multiple lipomatosis. So we did not leave a single fat disorder out, even included lymphedema in there. So, I mean, our hope is that all these new ICD-10 codes will really legitimize lipedema, and so make it a valid condition, and will improve access to care and improve access to things like compression. Because right now, unless you have lymphedema or venous disease, you can't get compression. But at that point, you should be able to get compression for lipedema as well, and compression pumps like the Lympha press, and also a better chance for approval for surgery and other things. So I'm pretty excited about it. It was a lot of work. It was a lot of mornings and evenings all week long, back and forth. But yeah, it's pretty good. But I think what's really interesting is we're learning more about female fat.
Mm-hmm.
And females are really good at growing fat, whether it's from lymphedema, because more women than men have lymphedema, or obesity, or lipedema. So I think we have a lot more to learn. I don't think all female fat is lipedema, but I couldn't tell you what is and what isn't. We don't have really good imaging. We don't have a way to tell the difference. We don't know why women grow lipedema fat and some don't. So I think it's our time. It's our time to really focus on female fat, because we kind of understand male fat on the abdomen and visceral fat, and that's been studied for years and years. And we'd say, oh yeah, that gynoid fat in the butt and hips, that's good fat. So it's good fat. You just live with that. But times are a changing. And thank you so much for joining me and being a part and offering your expertise, because I think you're just fantastic.
What a great team
thank you
you both make. I'm sorry I jumped in there because I do have a couple more questions in the Q&A as we're getting into the finish line here. And I want you to think about, Melissa, a patient that comes to mind that you've been able to make a difference in their life. Because when you were that little overweight girl and you found your purpose through your pain, is there somebody who you've been able to help? So think about that while I go to these last two questions that are in the Q&A. Debbie Bracy wants to know why the swelling starts after the sun goes down and what causes the cold feeling in the body.
Wow, that's really, those are two really great questions. One of the reasons why you could have swelling at the end of the day is because your cortisol levels go down. So cortisol functions on a circadian rhythm. It's higher in the morning and lower in the afternoon. So if you have lower cortisol to start and you get really low in the afternoon, then you could potentially have more inflammation at that time. And the cold, I'm not sure, but it could be because your thyroid hormones is not interacting with your cells as well as it should. And I think maybe an endocrinologist could help you with both of those things.
Great advice. I see you nodding, Melissa.
Yeah, no, I would agree. Also, we see sometimes on our thermography, we'll see areas of cold on the body. And we kind of attribute to that less perfusion to the area. So could be a little bit of that as well.
Agreed.
Interesting. And Vanessa Castine wants to know if you see a connection between worsening lipedema in patients with untreated mold mycotoxin illness. I can't imagine mold would do anybody good, but
Yeah, no. Well, it's another cause of inflammation. It activates your immune system in specific ways and not so good, especially if you're exposed to high levels or for a long period of time. And Melissa and I basically say any kind of inflammation can make your lipedema worse, or your lymphedema, or your vein disease, just or whatever you live with chronically. So finding all the causes of your inflammation is very important. And if you've had a mold exposure and you think that you're having issues with it, I would definitely find an expert in your area.
mm. You know, I'm looking at the attendee list. First of all, everybody who has attended tonight's live, thank you so much. This is one of our most attended research roundtables of the year. And I don't necessarily know what to attribute that to. Maybe it's the star power that's on the screen right now. But if any of you have never attended a research roundtable before, come back every month. We are talking to thought leaders. Dr. Herbst is bringing her brilliant mind to the table every month and getting answers for the questions you want to know the answers to. And I also want to say, if you've never been exposed to Lympha Press, as a service to both clinicians and patients, we do these roundtables every month. We also do special patient roundtables for lipedema and lymphedema, safe spaces without judgment to get your questions answered. And we offer advanced pneumatic compression therapy. If you're not using a pneumatic compression pump to help manage your condition, we would be so honored to help you. So go visit us at lymphapress.com. And I am going to go back to that question now, Melissa.
Okay.
So in your mind's eye, you're like, I want to serve people and I want to help people that have maybe what I was facing as an overweight child. Can you think of an example that has meant so much to you?
Yeah, I actually was in school still, and I was doing a clinical rotation in a rural health clinic, and I life has a funny way of humbling us. And so I had been kind of this like changed my life, was very adamant about anybody can exercise, you can do it wherever, you just got to have the willpower to do it. And then I met this lady, she was a single mom working two jobs, two kids. And we talked, and she had a very high hemoglobin A1C, one of the highest I had ever seen. So she was a diabetic, and she was drinking several Mountain Dews a day, not exercising. And so we kind of talked and evaluated her lifestyle. And I said, well, I just want you to start exercising. Like, just get outside, 30 minutes of exercise. That's all you have to do. Doesn't have to be anything crazy. And she looked at me and she said, I don't feel safe where I live. And it changed not only my way of thinking and how I help people, but I also thought to myself, okay, well, we're going to figure this out. I'm going to help you, because where there's a will, and I knew there was a will within her, there's a way. And so we came up, she started doing some like recorded, like she used YouTube on her laptop with her kid and started doing, dancing in the living room. And we cut down on her Mountain Dew she was drinking. She started drinking a little more water, and she came and saw me 6 weeks later, and I was almost done with my rotation. And she told me, she said, you've changed my life, not only my life, but my kid's life. And she said, nobody has ever worked with me to come up with a plan that I could actually apply to my life. So thank you for that. And that has changed my life in the way that I practice medicine, because it reminded me to see people where they are, and to meet them where they are. So
I'm so warmed by that answer. And thank you so much for being here. I always give Dr. Herbst the last word, but two things before we go to that, Dr. Herbst. Number one, there was a collective gasp in the audience when you said the R word. So, we just, and I'm hearing and seeing in chat, people are so appreciative of you, of the way you've made this your life's work, and that you genuinely care for patients. You've been tireless and you are so appreciated. Lympha Press is so honored to have you as our Chief Medical Officer. And so with that, this has been such a beautiful, rich discussion. Some people saying the best ever. How would you like to close out the program?
Wow.
Herbst.
I'm speechless. I don't know what to say after that. That's amazing. And just, I'm like tearing up. And it's, I can just say, I've been wanting to have a colleague that was just as interested in our patients as I am. And I feel like I found that with Melissa, and I just love working with her. She always, has her own opinion, which I really value. She's got a lot of education behind her, and I think you can just see tonight how easily things flow out of her, and that she cares. She really, really cares. And we were talking before the show about her dogs, and you said, "Oh, do you have dogs?" "Yeah, I have a couple dogs." Oh my God, those are her babies. I mean, she loves hard, and she loves those babies hard, and she loves her patients hard too. And I'm just thankful, and I'm thankful for you, Brenda. You are such a
Oh,
phenomenal host.
oh,
Thank you.
it's such a joy. This has been a joy. And again, every month, please join us, everyone. I felt all the good feelings from the chat, from this conversation. Melissa, we're just so thrilled and honored that you were with us. Hope you'll come back. And thanks, Dr. Herbst. Everybody have a great rest of your July, and we'll see you in August at the Research Roundtable.
Take care.
Bye,
Thank
everybody.
you. Bye.